Neurology quiz number 10. What is multifocal motor neuropathy or MMN? Multifocal motor neuropathy is a chronic immune-mediated demyelinating asymmetric motor neuropathy. In 80% it presents in the arms, usually on one side, with distal weakness in the distribution of a single nerve, for example the median or ulnar nerve. Cramps and fasciculations are common. Over time, muscle atrophy may occur. Reflexes are depressed or normal. These features may raise concern for ALS, but upper motor neuron signs are not seen. Sensory symptoms are absent or minimal. Disease spreads to other nerves in the affected limb as well as to the other arm and sometimes to the legs. 40 to 80% of cases are positive for GM1 antibody, which causes conduction failure at the nodes of Ranvier. Hallmark of EMG and nerve conduction studies is conduction block of motor nerves at non-compression sites. Some patients show additional features of demyelination in the motor nerves. Sensory nerves are normal. CSF protein is not elevated. Treatment of choice is intravenous immunoglobulin. Steroids are not effective and may cause worsening. In case of lack of or loss of response to IVIG, alternative medications include cyclophosphamide and rituximab. What is anti-DPPX encephalitis? It is an autoimmune condition associated with antibodies against dipeptidyl peptidase-like protein 6, a regulatory protein of potassium channels. In some patients, it may occur as a paraneoplastic syndromes associated with systemic lymphoma. Median age of onset is in the 50s. The course is subacute. Patients may have a prodromal phase of significant weight loss and diarrhea. Subsequent neurological symptoms include memory loss, mood and personality disorders, CNS hyperexcitability including hyperexplexia, myoclonus, tremor, seizures, and muscle rigidity. MRI changes are non-specific. CSF may show pleocytosis and intrathecal IgG synthesis. The anti-DPPX antibody is detected in both serum and CSF. Good response to immunotherapy has been reported. Treatment includes IV solomedrol, IVIG, and plasma exchange. Important differential diagnoses are CNS Whipple disease and PERM or progressive encephalomyelitis with rigidity and myoclonus. What are the clinical features of nitrous oxide myeloneuropathy? Nitrous oxide is an anesthetic used in surgical and dental procedures. It is also available in aerosol cans dispensing whipped cream, hence the street name Whippets. It is used for recreational purposes because of its mood-elevating properties. Due to ease of access, abuse may occur among anesthesiologists and dentists. It inactivates vitamin B12 by irreversibly oxidizing the cobalt center of methylcobalamin, the active form of intracellular vitamin B12. Clinical presentation is therefore identical to vitamin B12 deficiency. Clinical features include myelopathy, peripheral neuropathy, myeloneuropathy, and cognitive disturbances. Spinal MRI shows hyperintense signal in the posterior and lateral columns of the thoracic and cervical spine. Other findings include low vitamin B12 levels and elevated methylmalonic acid and homocysteine. While many cases result from repeated recreational or anesthetic exposure, in patients with pre-existing borderline or low vitamin B12 levels, neurological complications can occur acutely even after a single exposure to nitrous oxide. Time to symptom onset ranges from immediate to 2 months following exposure. Treatment involves stopping nitrous oxide exposure and intramuscular administration of vitamin B12. Supplemental oral methionine may hasten recovery.